respected senior leaders, respected faculty, dear AMS members, colleagues and friends. I'm really glad to welcome you all for another session of Practice Changing Updates by AMS Trivandrum chapter. As you all know, we have been conducting various academic programs since last December. And we have 2 more programs for this month, including our journal club. I'm glad to announce that we, the Trivandrum chapter, is hosting the prestigious IMA AMS Kerala South Zone Conference. That's on July 30th. We are going to conduct it at our IMA headquarters, Anera. It's going to be a great session with day-long academic feast, quiz competition for the PG students as well as for the participants, paper presentation, poster presentation, etc., etc. So I request all of you to register for the event. Please do participate, make it a grand success. And coming back to today's program, it's going to be a very useful, very informative, very interesting session, I'm sure. Antibiobrams, a primer for physicians, something which everyone else should know. And speaker is none other than Dr. SHAREEK. Yeah, I'm glad to know that our president, Dr. Vijayakrishnan, has joined. He's actually traveling in connection with the National Conference Registration Campaign. Welcome, dear Vijayakrishnan. And Dr. SHAREEK, as you all know, he's a consultant in SUT Group of Hospitals and PRS Hospital. He's an infectious disease specialist. And he did his fellowship in Apollo Hospital, and he was also an expert committee member in Chief Minister's COVID Expert Committee. I'm really glad to welcome you, Dr. SHAREEK. Welcome.
Thank you. Thank you.
And I welcome Dr. Untitled, the convener of AMS Trivandrum chapter. Though he's a part of this family, I'm really glad to welcome him. And I welcome all the senior doctors, my colleagues and dear friends. And now I invite Dr. Vijayakrishnan to say a few words before going into the academic session. Over to you, Dr. Vijayakrishnan.
Thank you, respected Dr. Pradeep Kadangur sir, Dr. Anand, Dr. SHAREEK, and respected seniors and dear friends. Actually, I'm traveling in a train. I give all the best wishes for this program. And as already Pradeep sir told, there will be a program on July 30th, our AMS South Zone Conference here. Team will be conducting this
I think there's a problem with the connectivity.
colleagues.
Your voice is breaking. I think there's some problem with the connectivity. Hello. Thank you, Dr. Vijayakrishnan. Now I welcome Dr. SHAREEK to start the academic session. Over to you, Dr. SHAREEK.
Thank you, sir. So today we are just going to look at interpretation of the antibiogram from the clinician's perspective. Just a minute. Can you see the slides?
Yes.
Sure, thank you. So this is a very simple thing actually, but if you go into the details, it's going to be a little bit complex. But I believe most of the simple things are the most complex things also. So this is just a basic microbiology and basic pharmacology. So bacteriology means you have the gram positives, your gram negatives, like E. coli and Klebsiella. It's divided into lactose fermenting gram negative E. coli and then Klebsiella, and then non-lactose fermenting GNBs like Pseudomonas and Acinetobacter. These are the common things what we see in the clinical practice. And among gram positive, what we see most commonly is Staphylococcus, Enterococcus, Pneumococcus, and Streptococcus. So I'll not be going into all these things, but I'll be just taking one or two from here because it's going to be if I'm going to complete everything, it may take a long time. So I just want to make it very sharp. So I'm just going with some clinical scenarios, some OP cases, like this is a 36-year-old male patient who comes with an abscess in the right thigh, had fever, counts was very high. So pus was aspirated, and 2 days down the line, he comes out with this culture report now. Now we have to pick the right antibiotic from here, right? So this is the challenge in here. This is the challenge to pick up the right antibiotic for this patient. How to do that? So first and foremost thing is that we need to understand certain things in when you interpret this one. So first thing is you need to assess the quality of the reporting lab. How we can do is that one, look at the organism which we have grown. For example, this is an abscess, and what is growing is Staph aureus. So it makes sense, clinical sense. It makes sense. Staph aureus is causing an abscess. It makes sense. Okay. Now, next thing is you look at the antibiotics which they have described in this. For example, if you see here, they have given oxacillin, ciprofloxacin, all those things are there. But if you see like meropenums, piperacillin tazobactam, cephosulbs, or colistines, all those things in here. So basically, you have to understand that gram positive has a different spectrum of antibiotic, and gram negative will have a different spectrum. So if you see that meropenem, which are basically used for gram negatives, you see in the Staph aureus, probably the quality of the lab is questionable. So that's how we understand whether this lab is a good lab or a bad lab. So coming back to this case, this is an OP patient. So OP patient, when comes in, it's a Staph aureus. So first thing we look in Staph aureus is looking at the sensitivity. You can see here oxacillin. So once it is oxacillin, it is sensitive. So this is the index drug. So every bacteria has an index drug. And then based on that, for example, you know, Staph aureus divides into methicillin sensitive and methicillin resistant, MRSA, MSS, right? So this actually falls into the methicillin sensitive. If you look carefully, there will not be any methicillin at all. And that's the funny part of that. You call methicillin sensitive based on oxacillin, not methicillin. So you will never get methicillin in that. So there are a lot of funny part in this one. You call methicillin sensitive, but you won't have the methicillin in this. So identify this oxacillin first. So it's going to be methicillin sensitive Staph aureus. And the second thing is cefoxitin. So there will be something called cefoxitin screening. If it is negative, again, we call methicillin sensitive Staph aureus. So here, if you look into that, the ideal drug of choices include first and second generation cephalosporin. That's another part of that. First and second generation means your cephalexin, cefuroxime. So these are the drugs. But again, if you see carefully, it will not be in this spectrum. So once the oxacillin is sensitive, you can use cefuroxime or cephalexin. But there are other options as well in this one. For example, if you see, you have tetracyclines, like doxycycline can be used. Your cotrimoxazole, good old drug. Basically, cotrimoxazole is a very good drug which we use most of the time we use here. So cotrimoxazole is another drug which we can use for this patient. And then you have clindamycin. So the other point with the clindamycin is that when you have clindamycin sensitive, it's always better to talk with the microbiologist, because there are two essential points before prescribing clindamycin. One, the erythromycin should be sensitive. And there is one more thing called inducible clindamycin resistance. What happens here is that if the inducible clindamycin resistance is positive, even if the clindamycin is sensitive, it may fail on board. So that is a factor which we need to understand, that clindamycin, erythromycin should be sensitive and inducible clindamycin resistance should not be there. Then only we can use clindamycin. In this scenario, we can use clindamycin, cotrimoxazole, tetracyclines. Unfortunately, your fluoroquinolones are not there, cefuroxime and cephalexin. These are the options. So Staph aureus doesn't mean linezolid all the time. So that is one thing we always say, Staph aureus, skin and soft tissue, we always go for the linezolid. But what we have to look for here is the tissue penetration. Here you have your abscess in there and all these drugs. your cotrimoxazole, doxycycline, clindamycin, all penetrate well into the abscess. So all these options are here in this patient. So we can opt whatever we want. So that's how we pick from them. So you can even, you can't see the cefuroxime and cephalexin. Those are also a drug of choice because it's methicillin sensitive. You won't get the cephalexin and cefuroxime sensitivity in an automated report, right? Now, if the same patient comes with different culture, now the same patient who is coming with a different culture report now, you see carefully, as I said, initially look for the index drug, which is oxacillin, which is resistant. So this falls straight away into the MRSA. This is methicillin resistance. So if you see methicillin is not there, that's a funny part of that. Don't look for methicillin, it will not be there. And if you see the cefoxitin screening, it's positive. So this is straight away methicillin resistant Staph aureus. And in this scenario, your cefuroxime and cephalexin, your first and second generation cephalosporin will not work. So that's knocked out. Now, immediately when you say MRSA, skin and soft tissue, the choice automatically will be pointing to linezolid. Probably linezolid is what has been fed to us. So linezolid, MRSA, that's how we think. But if you look carefully, linezolid is a drug which should be used only sparingly, not to be used as a water. So if you look carefully, there are other options here. Like again, you have the cotrimoxazole. In this, again, you look for, it's a tetracycle. So MRSA doesn't mean linezolid all the time. Look at carefully. We can have the clindamycin resistance. I mean, clindamycin is sensitive. So inducible clindamycin is resistant. So clinda is an option. Cotrimoxazole is an option. Tetracycline is an option. So these are all the options which we can use here. Then other thing, if you look carefully, there are rifampicin, nitrofurantoin, all those things will be there. TG cycline, these are all drugs which will be there, but should not be used. Those things we need to know. One, rifampicin should not be used in methicillin, Staph aureus, unless as a combination therapy for an implant infection. So should not be used as a monotherapy. Rifampicin, high resistance prone, plus the TB issues as well, high toxicity. So should not be used even if it is there. And then nitrofurantoin is a drug which has only, it should be used only for urinary tract infection. So nothing beyond that. So every drug has its own plus and minus. So you need to understand every antibiotic has its own plus as well as a negative flip side. Now TG cycline will be sensitive, but very expensive. It's not needed. All these fancy drugs are not needed. Here, my choice will be cotrimoxazole. Simple thing, cotrimoxazole will be the drug of choice here. So here I'll go with cotrimoxazole, not with the linezolid, even though it's MRS. Hope that's clear. Now, if the same patient comes with a different spectrum, if the same patient comes with a different spectrum, different culture report, if you see here the clindamycin is resistant, your cotrimoxazole is resistant. Now, cotrimoxazole is, these things can happen, it varies, okay. Now, even in this scenario, linezolid is not the option for us. We can have the doxycycline. So again, look for the cheaper drug, easily accessible, cheaper, and less side effect kind of drugs. Linezolid is not a drug which has no side effect. It's nothing like that. It can produce marrow suppression. It can produce neuropathies. So there are a lot of issues if you continue linezolid for more than 2 weeks at all. So again, in this scenario also, we don't need this thing, a parenteral drug. All you need is doxycycline. So even if it is MSSA, MRSA, even with all these resistance pattern, drug of choice again is going to be doxycycline. So some drugs are very valuable. Unless we look into that, we will be unnecessarily pumping in with linezolid, teicoplanin, Wang, and all those things. Right? But one thing you need to understand about gentamicin is that aminoglycoside doesn't act in pus. So aminoglycoside basically we use for urinary tract or as a combination therapy. So it is an amino acid kind derivative. So when it comes to the acidic environment, it just gets diffused. So don't use gentamicin as a drug for skin and soft tissue infections. Now, suppose if the same patient, blood is growing. Now it's entirely different ballgame. Now the same culture pattern, I've just repeated the same culture pattern. So if you see carefully, this is the first one. Here you have the your methicillin sensitive, oxacillin is negative, sensitive. So it's a methicillin sensitive Staph aureus growing in blood. Now, 2-3 things we need to be clear when blood is growing Staph aureus. One, only parenteral therapy, no oral options. No oral option, only parenteral therapy. Here, the drug of choice, very few drug of choice. Basically, once it grows in the blood, we use only beta-lactams. We don't use the non-beta-lactam, though these are sensitive. So if it is only a skin and soft tissue, we use cotrimoxazole, your doxycycline, all those things. But once it grows in the blood, we will not go for the non-beta-lactam. Always we go for the beta-lactam. And that includes first generation cephalosporin. Cefazolin is the drug of choice. Or flucloxacillin. These are the parenteral drugs to be given when this thing is growing in the blood. No oral options. Should be we have to repeat the cultures after 2 days. We have to get an echo to rule out endocarditis, because in endocarditis we have to give for 4 to 6 weeks of therapy. So this therapy duration differs. So echo is mandate, repeat blood culture is mandate, and from the repeat blood culture negativity we give for 14 days. So 14 days again parenteral only. If we misshit, what happens is this patient ultimately end up with endocarditis or discitis. So many times discitis happen because of the missed blood cultures with the Staph aureus. So here, though the culture report is same, but since it's growing in blood, all these non-beta-lactam options are wiped out. Here, options are cefazolin, which is not seen again, which will not be seen in this one. So cefazolin is a drug of choice, or flucloxacillin is a drug of choice. It's not vancomycin. Vancomycin is inferior. So Staph aureus, bacteremia. If it is methicillin sensitive, vancomycin, teicoplanin, all those things are inferior regime when compared with cefazolin or flucloxacillin. So that is a slight difference. But if it comes to the next one, it's actually MRSA. So once it is methicillin resistant Staph aureus in blood, I repeat, in blood, the drug of choice include vanc or teicoplanin. Vancomycin or teicoplanin. Again, the same 14 days parenteral therapy, no oral option, right? So dose to be adjusted according to the renal functions, your vanc and teicoplanin dose to be adjusted. Again, daptomycin is another option, but it's very expensive. Unless you fail, don't use with the daptomycin. And one more thing with daptomycin is that lung, if it is pneumonia, you should not use daptomycin. That is one thing. So should not use daptomycin. If it is a plain bacteremia, probably we can use daptomycin. Teico and vancomycin are the drug of choice here. Again, you can see a lot of S. So once you get S, doesn't mean we can use. It all depends on what is the organism, where is the problem, right? So if it is in the blood, it's actually it's opposite. You can't use all these drugs which we used in a OP. Now, regarding enterococcus, I'll just speak a little bit about enterococcus. Enterococcus, the index drug is penicillin. So once penicillin is resistant for enterococcus, this is pneumococcus, I know, but I'm just saying a little bit about enterococcus. If penicillin is sensitive, always use ampicillin or amoxicillin. So that's the drug of choice, ampicillin or amoxicillin. These are the drugs we use for enterococcus. But if it is resistant, penicillin is resistant, we'll go with linezolid, teico, or teicoplanin or vancomycin. This is how it goes. And then pneumococcus is a little bit tricky to grow. Very few times we can grow it, and especially we get it in the CSF PCRs, you get a lot of pneumococcus. And again, once you get pneumococcus in blood or in CSF, you have to discuss with the microbiologist. So what is the more important point is that it's not for us to learn all these things. What we need to know is when to discuss with the microbiologist. When you have a Staph aureus and you're going to use clindamycin, discuss with the microbiologist. When you have pneumococcus, always discuss with the microbiologist. Now I'm going to the gram negatives now. A 50-year-old diabetic who comes with fever, high grade with chills, dysuria, pain in the loin region, basically presents like a pyelonephritis and hemodynamically stable. TC is 25,000, leukocytosis is there, otherwise normal. So basically looks like a pyelonephritis, a diabetic who comes in with. Now this is the culture report. Now, if you see carefully, this is Klebsiella. Again, it makes sense. Urosepsis, Klebsiella or E. coli is a bug which actually works on. So, right, it makes sense. Klebsiella makes sense. So, in Klebsiella, gram negative, how we divide is, we divide these patients into 3 tiers. 1, ceftriaxone sensitive. 2, ceftriaxone is resistant. Once you say it's ceftriaxone is resistant, it goes into the extended spectrum beta-lactamase, ESBL. So that's another term, ESBL. And then the 3rd tier is carbapenem resistance. So these are the 3 tiers we use. So here, if you look carefully, the ceftriaxone is resistant, which is very common with gram negative. Ceftriaxone resistant touches even up to 70%. In many studies, it has shown up to 50 to 70% will be resistant ceftriaxone. But if you see your 2nd tier, this is we call ESBL Klebsiella. This is how we label this ESBL Klebsiella pyelonephritis. Here, the drug of choice includes if you're going to give IV, patient is sick, you're going to give IV. What you can give is actually you can give carbapenems or even cephosalt or your piperacillin tazobactam also can be used if it is sensitive. If amoxicillin is sensitive, we could have used, but I means intermediate, which means that may not work, right? But here you can use cefoperazone, sulbactam, beta-lactamase inhibitor. This is the second tier. Third tier is the carbapenem. So these are the three tiers we have. So, and then the another tier is beyond carbapenem. So that's very common now. But here, if you look carefully, if this patient is relatively stable and blood is not growing anything, since we are dealing with urosepsis, we need an antibiotic which has good penetration into the urinary tract. You look carefully, all these things are there, but if the patient is stable and the blood cultures are negative, probably we can get away with the fluoroconazole, ciprofloxacin. So here, the patient is in OP, drug of choice will be ciprofloxacin, may not need a parenteral one if the patient is not very toxic. The other option which has good penetration into the urinary tract is cotrimoxazole. Again, cotrimoxazole is a wanted drug, excellent drug, but unfortunately this is resistant here. So we will not use cotrimoxazole because it's being resistant, though it has good penetration. But the other option is we have ciprofloxacin. We can use that. Okay. Then your amikacin, gentamicins are there. Okay, we can use because it's urosepsis. We can use amikacin or gentamicin. We can use in UTI. But again, parenteral is the issue and renal toxicity is another issue. So we'll always look for a drug which has a less side effects and easy to apply. So here, probably we can use ciprofloxacin. So even you see nitrofurantoin as an intermediate here. But one point with nitrofurantoin is you have to be very clear that it can be used only for lower urinary tract infection, like urethritis or cystitis. But here, the syndrome is pyelonephritis, where this doesn't work. So nitrofurantoin is a drug only to be used for the lower urinary tract, not for the upper urinary tract. So though even if it is sensitive, we will not go with nitrofurantoin since it is a pyelonephritis. Now, other option, what you see here is tigecycline. But believe me, this is a fancy drug. But the issue here is that tigecycline doesn't penetrate into the urinary tract. So though it is sensitive, very fancy drug, very expensive, poor outcome. So don't use tigecycline for urinary tract, though you see sensitivity. So all S should not be counted upon, right? So that's a basic point. So here we can use pipitazole, cephosalt, carbapenems, amikacin, all those things can be used. But my drug of choice, if the patient is very stable, I'll just give ciprofloxacin. So this patient can be managed in an outpatient, but not nitrofurantoin, even if it is sensitive. Suppose if this patient comes with this report, this is a little bit complex here. If you see this report, if you go through that algorithm, ceftriaxone is resistant, so it goes into for the beta-lactams goes out. Now you see carbapenems and cephosalt, all those things are resistant. So this basically is a carbapenem resistant organism. I think this is E. coli. But whatever it doesn't matter. E. coli, Klebsiella doesn't matter. Almost the same. Now if you see, now you look for the other options. Amikacin and gentamicin is also resistant here. You can't use that. Okay. Now again, this question. What are all the other options we have? We have options like colistin. Colistin is another one of the options we can give in this patient. If the patient is sick, we can consider colistin. And other options are ceftazidime avibactam is a newer antibiotic which we can use in such scenarios, or even fosfomycin if it is sensitive. But this report doesn't show anything. But we will have to ask the microbiologist to check for the sensitivity of fosfomycin and ceftazidime avibactam if the bug we got is carbapenem resistant. So once you get this carbapenem resistant, it goes to the next tier, fourth tier, where our main stake players will be colistin, then again tigecycline, colistin, ceftazidime avibactam, aztreonam. These are ceftazidime avibactam, aztreonam combination and fosfomycin. But again, here we will not use tigecycline. Even if it is sensitive, we will not use, as I said, because of the poor urinary penetration, we will not use. Nitrofurantoin, cheap option out of this one. Nitrofurantoin is a cheap option, but this being pyelonephritis, we will not use. But if the same patient comes out with features of fever, dysuria, and abdominal pain, lower abdominal pain, just like bladder involvement, cystitis, probably we don't need all these colistins and all those things. So all we need is a nitrofurantoin. So that is a funny part. But if this is sensitive to fosfomycin, another option is oral fosfomycin. Oral fosfomycin is one drug which we can use for UTIs. And oral fosfomycin to be used only for UTI. It doesn't work anywhere else. So only for UTA, you have to use oral phosphomycin, and that too as a last option in gram-negative. So this is about gram-negative spectrum. Now I'm going to the non-lactose fermenter. This is a 64-year-old male who, known case of COPD bronchiectasis, admitted with a pneumonia syndrome. Now, COPD bronchiectasis with sputum culture is growing as Pseudomonas. Now, this I'm going to the third tier non-lactose fermenter. Now, if you see Pseudomonas, it has a little bit of difference in the reporting format. You won't see this is you need anti-Pseudomonal agents. You will not get ceftriaxone. So if someone is saying ceftriaxone sensitive to Pseudomonas, that report has some trouble. So don't depend on that. So that's how we identify how a report generated from a hospital or a lab is reliable or not. So once someone says that ceftriaxone is sensitive to Pseudomonas, it is a waste report. We will have to do it again. Again, there are other drugs which are inherently resistant to Pseudomonas. This I put purposefully because normally you don't get this. Tigecycline, minocycline, tetracycline, doxy, all those things doesn't work with Pseudomonas. They are intrinsically resistant. Now, other thing is cotrimoxone. Till now, I said it's a wonder drug, but for Pseudomonas, it never works. It never works. So these are intrinsically resistant. They will not work at all. So Pseudomonas has only one oral option. That's fluoroquinolone. No other option. So if the fluoroquinolone is resistant, there are only parenteral options left for us as far as Pseudomonas is concerned. Okay. Now coming to the parenteral options, always look for the spec which has a least spectrum. For example, here beta-lactam, ceftazidime is sensitive, cefepime is sensitive. Now you don't need meropenem here. It adds on to the agony actually. If it adds on to the AMR pattern, so a lot of issues will be there. Collateral damage will be high. Here all we need, in case if we need a parenteral antibiotic, all we need is a ceftazidime or a cefepime. Cefepime, be careful. It has a lot of neuropsychiatric manifestations, even including seizure disorders. So cefepime is a drug which has to be handled a little bit carefully. But here we can use ceftazidime. So these are simple things we can use. Again, amikacin, gentamicin is sensitive, but should not be used as a lone agent in lung. Lung, it has poor penetration. So understand the fact that it is not the cost, not the S. It just matters. What matters is the tissue penetration and the side effects as. So amikacin being a little bit more toxic drug and less tissue penetration will not be our primary drug, even though it is sensitive, though it is Pseudomonas. But be careful to analyze a report whether it is good or bad. So if this report looks fair for me, because if they would have said that tigecycline is sensitive or minocycline is sensitive, I would have said that this is a bad report. Again, cotrimoxone, if they say it's sensitive here, I would have said it's a bad thing. Suppose if I see ceftriaxone here, probably I'll say this is a waste report. So first thing, when you get a culture report, I just have a look on that. Just see what is a bug we are identifying, what is a syndrome we are dealing with, and then look for this sensitivity pattern. So if you see gram-negative spectrum or carbapenems or all those things, gram-negative antibodies, these are all gram-negative. You see in the gram-positive reports, that means the report has some trouble. If you see otherwise, if you see Wang or teicoplanin or linezolid in a gram-negative, again, that is a little bit trouble. There are certain drugs which has this cross between gram-positive and gram-negative, like tigecycline, minocycline, all those things has some cross-react, means it covers for both, even ciprofloxacin, trimethoprim, it has covered for both gram-negative and gram-positive. So here we are dealing with the targeted therapy. Just we know what is a bug. We need to pick what is the right antibiotic. So the factors include, basically the factors include 1, cost, 2, sickness of the patient, whether he requires into ICU admission, ward admission or OP patient, right? Tissue penetration, right? These are the 2-3 points which we have to be very careful, and don't believe all S means equal. All S may not be equal. For example, nitrofurantoin, when you use in a UTI, be careful, only use with the lower thing. Tigecycline should not be used in urinary tract infection. Dapto should not be used for pneumonia syndromes. So likewise, there are certain no's in the interpreting the antibiotic. Thank you.
Thank you, Dr. SHAREEK. So now it's open for discussion. I invite the participants to ask questions if there are any. Yeah, there's one question, how to interpret MIC.
Okay. So the point is that MIC is a little bit complicated because what you see in the slide also, you saw a lot of MIC. But actually, there is one more thing called the breakpoint. You need to get the breakpoint also to see whether this MIC makes sense or not. It's not that absolute value. You have to compare with the breakpoint. So my personal advice is just look at the SNR, not look into the MICs, except in very few situations where I'll tell you. One, when you are using vancomycin in blood, for example, MRSA bacteremia, you have to know the MIC of vancomycin should be 1 or less than 1. That is very clear. That's a point where you have to look for. Second thing, when you are using ciprofloxacin in salmonella, it has to be less than 0.06 or so. So that point we have to look for into the MICs. And third point, when you are trying to add another carbapenem with the colistin-based therapy. So in that scenario, your MIC should be 4 or less than 8. That should be the cutoff. If it goes more than that, it doesn't make sense. So basically what I'm saying is, MIC is just one point. You have to compare with the breakpoint, which will not be there in that. So don't look at that absolute values. You have to compare with the benchmark of a breakpoint, then only you will know which works better. So my point is just look at the SNR. Don't go into the too much complications. Less number doesn't mean anything for us.
Anyone else? I think that's all. Since there's one more question, is double antibiotic coverage indicated in Pseudomonas blood infection?
So as such, this question, there's been long, debate about whether we need or not. But as such, we don't have any evidence to say that you need double cover for this thing. And as of now, the combination therapies are going out of phase. Even for carbapenem resistant, we are not going for combination therapy right now. So it's all monotherapy, except very few scenarios where we may need some combination therapies include your complicated necrotizing fasciitis with bacteremias, where you may have to combine teicoplanin with the clindamycin or vanc with the clindamycin. So there are very few scenarios where you need combination therapy. Basically, it doesn't work. So my point is that if you have the right antibiotic and in spite of that, the patient is not improving in 2-3 days time, then it means something to do with the source control. So you will have to look for the source control. For example, a pyelonephritis is not working with 2-3 days, the appropriate antibiotic you are doing, but in spite of the patient not improving, you'll have to think of whether there is any renal abscess in, or is there any other DJ stenting to be done. So all those things to be done.
There is one more question. If an organism is resistant to cephalosporins and the carbonic, can it be sensitive to ampicillin? As one report shows sensitive to ampicillin but resistant to all.
This happens. That's what I said. If the bug is Enterococcus, for example, I'm saying if the bug is Enterococcus, it will be resistant to all these things and will be sensitive to ampicillin. So you have to look at what are the bug we are looking into. If it is a gram-negative one, it doesn't make sense. If it is a gram-positive, probably if it is an Enterococcus, it makes sense because its ampicillin should be sensitive, and Enterococcus is obviously resistant to cephalosporins and your this thing. And in Acinetobacter, again, this thing doesn't work. Ampicillin doesn't work. If I think that was the question. Acinetobacter. If Acinetobacter is there, it will not work.
And rationally for initiating ceftriaxone sulbactam combination in ICU patients.
See, ceftriaxone sulbactam plus EDTA, there are a lot of molecules available in the market, but we don't have any studies to say that whether it can be used or not used. So I'm not saying anything about that because we have lack of evidence for such molecules. So I don't depend on such molecules in my sick ICU patients. I never depend on such molecules at all. And as a matter of fact, we never use such drugs. There are a lot of combinations, ceftriaxone, sulbactam, EDTA, all those things, but never we use that in sick patients. We use the time-tested molecules, which has good evidence. And one question is when to switch from parenteral to oral antibiotics in skin and superficial skin and soft tissue. And that's a simple question. I mean, like you look at the clinical thing and see whether if there is no bacteremia, you can early switch to oral antibiotics. It's not a big deal that you need to continue parenteral all the time, but you need a clinical assessment. And then after 4 or 5 days, you see whether the patient has improved. The patient is in shock and all those things, probably you may have to go a little bit long. Otherwise, if the patient is this thing, improving clinically on that, now you change to that. For example, you have Staph aureus growing in skin and soft tissue. You started with cefuroxime or cefazolin. Now, after 2 or 3 days, you reassess the patient is ready for fit for discharge, change to oral thing. There's no hard and fast rules that you have to give parenteral all the time. Parenteral comes only when you have your bacteremias and all those. I think Janak had a question.
Yeah.
Can we use teicoplanin?
Yeah.
For endocardinitis, right? Janaka, I think that basically all these guidelines comes from America. So you have to understand the difference between WANC and TECO. Like WANC is Americans and TECO is UK. So that's the difference between that. Teicoplanin doesn't have FDA approval. That is the only issue is that. So if you look into the American guideline, always you remember when we say endocardinitis, we always say the American Heart Association guideline, right? So you will not see teicoplanin because they don't use it in America. But if you go the BSAC guideline, British guideline, they say teicoplanin can be
used. Is ertapenem OD will be as good as meropenem or imipenem?
That's a good question. So ertapenem, every drug has, as I repeatedly say, every drug has its own plus and minus. Ertapenem has a problem that it doesn't cover Pseudomonas and Acinetobacter. So ertapenem has to be used as a definitive therapy when you get the culture report or the organism. If you don't know what is organism, ertapenem is not a good choice. But the advantage with ertapenem is that you can give once daily. It can be given on an outpatient basis. But the issue is that it is a little bit costly. But excellent drug. Excellent drug when you are dealing with E. coli and Klebsiella. Equal to meropenem. But Acinetobacter and Pseudomonas, it doesn't cover. So the spectrum is very less. So ertapenem is a valuable drug for ID, basically because of the lesser spectrum it has.
Apart from the culture reports regarding tissue penetrability, which will be
it's not much different. All the carbapenems goes the same way, except that your imipenem has enterococcal coverage also, some gram-positive cover. Enterococcal cover will be there for imipenem. But ertapenem is only for E. coli Klebsiella, and tissue penetrations are almost always the same, except in Miro, you have your CNS penetration. Ertapenem doesn't have CNS penetration. Miro high dose has a good CNS penetration. So in case of meningitis, never try with ertapenem. Except all the other scenarios, we can go with ertapenem.
I am asking as regards tissue penetration, which
it's
will
all the
be
same.
a preferable drug, not ertapenem. Say a joint infection or a urinary
infection. Joint infection, basically your tissue penetration is good for beta-lactams, parenteral beta-lactams, and even cotrimoxazole and fluoroconazole also has a good penetration into the joints.
And for respiratory?
Respiratory, again, you have all the baseline drugs which has a good penetration into the lung. Except TG has a little bit lower side penetration into the lung, except that most of the molecules, except amikacin, doesn't have good penetration. All your carbapenem has good penetration into the lung.
Thank you.
Any more questions? If there are no more questions, then we'll wind up the session. And Dr. SHAREEK, it was an excellent talk. Actually, we all really enjoyed. Very informative, very interesting, very relevant. And thank you so much.
Thank you, sir. Thank you
for spending so much time with us. And I express our gratitude to all the participants, senior leaders, AMS members, and my friends, colleagues. Thank you so much. Do participate in all the AMS programs. And thank you and good night.